So, hello, all of you. Good evening, everyone. I hope I am clearly visible. My slide is visible and I'm audible to all of you. If yes, just write a yes or a thumbs up in the chat box. I am in the live chat available. So, just write yes or a thumbs up so that we can begin today's class. Yes. So, good evening, all of you. Good evening. Yes. Hari Om. Good evening. Vasant. Good evening. So just if I am clearly audible and I am visible, just write yes. Oh, so thank you, Mohammed, for writing yes. So let us begin today's class. So as you all know that I am Dr. Manish Soni, your dermatology faculty, and today I will be discussing the most important 25 important questions from dermatology. And these questions are really very important. I have picked these questions and the topics from the recently asked previous year's questions, and that's why they are so important that if you go through these questions and these topics, definitely it will help in your exam. So begin with the first question. So here you can see that in this first question they are saying that a 22-year-old male presented with asymptomatic scaly lesions. So lesions are asymptomatic and they are having a lot of scaling over it. They are present over back and they are symmetrical in distribution. They are symmetrical, that is bilaterally symmetrical on both the sides. As shown below in the image, identify the disease and the pattern shown in the lesion. Now, if you look at the image, you can see that there is trunk involvement. So trunk, not just the back, but the trunk, the front of the trunk is being shown. And these are the lesions. These are slightly red. So they are red like rose and they are having scaling. But if you look at the scaling is very characteristic. Can you see the scaling here? The scaling is not like psoriasis, which is silvery white. So silvery white scaling is seen in psoriasis, but it generally occurs over extensors like knee, elbow, and back. But here front of the trunk is shown and the scaling is at the periphery, looking like a collar. So this is collarate scaling. So rose-like red lesions. The trunk is the most common site. Collar-like scalings are seen and symmetrical lesions, that is giving fir tree-like appearance on both the sides. This is a case of, yes, all of you have answered correct in the chat box, and that is pityriasis rosea. Now, sometimes this pattern is known as Christmas tree pattern, and you might get confused with the first option because Christmas tree pattern is written there. But remember that Christmas tree pattern is not seen in lichen planus. It is seen in, yes, pityriasis rosea. So this is Christmas tree pattern and the colorate of scales which are being shown here. So answer is C. Now also remember that in lichen planus, there is one important finding that is known as Wickham striae. So Wickham striae is feature of lichen planus, and this is, if this is a lesion of lichen planus, which is plain purple polygonal pruritic papules, you will get this reticulate pattern known as Wickham striae. And if you see another option, that is Warnoff ring, remember it is not seen in seborrheic dermatitis, it is seen in psoriasis. So Warnoff ring is seen in psoriasis, while in seborrheic dermatitis, which scaling is seen? Yes, very oily or greasy scales are seen. And when seborrheic dermatitis occurs in infants, what we call that condition? Yes, we call it cradle cap. So cradle cap is another name of seborrheic dermatitis in infants. So pityriasis rosea is one important condition, and the points to remember in pityriasis rosea are that it is very common in females. The first patch is known as Herald patch. So if they ask you Herald patch is seen as, it is also seen in pityriasis rosea. This have very characteristic scaling known as collarate of scales, and these scales are present in fur-like pattern that is along the line of ribs. So this is known as Christmas tree pattern or fir tree pattern. So all these points are pointing towards pityriasis rosea. Moving on to the next important question. Here I have included one match the following type of question. And if you see, these are the Woods lamp findings which are mentioned here. So in erythrasma, we use Woods lamp, and under Woods lamp, it gives which color of fluorescence? coral red colored fluorescence is seen in erythrasma. While in pityriasis versicolor, which color is seen? Yellow or apple green fluorescence is seen. So apple green or yellow fluorescence is seen in pityriasis versicolor. In tinea capitis, green or bluish green fluorescence is seen. So in tinea capitis, blue or bluish green fluorescence is seen, while in vitiligo, milky white fluorescence is seen. Now, do you know that pink fluorescence is seen in which condition? Yes, pink fluorescence is seen in porphyria. So if you collect the urine of a patient in a test tube, and if you look at under Woods lamp light, it appears pink. So pink fluorescence is seen in porphyria. So the correct answer becomes first E, second C. So B becomes the correct option here. That is coral red in erythrasma, yellow or apple green in pityriasis versicolor, tinea capitis green or bluish green fluorescence, and vitiligo white fluorescence. Yes. So Bhavna and Sachin have answered it correct. Now, if you see this question, in this question, they are saying that a 20-year-old female presented with complaint of painless ulcer. So ulcer is painless. Now you know that chancroid is a painful condition where painful multiple genital ulcers with undermined edges are seen. So obviously this is not the answer. Why? Because in chancroid, multiple painful genital ulcers with undermined edges are seen. Okay. Then this is not herpes. Why? Because here painless is written, and herpes, which is caused by herpes simplex virus 2, herpes genitalis, presents with painful grouped vesicles or ulcers or erosions. So this is not herpes also. Now, granuloma inguinale is another name of donovenosis. And syphilis both can present with painless genital ulcer. Now read the question further. They are saying that it is associated with non-tender inguinal lymphadenopathy. So lymphadenopathy is there and large lymph nodes are there, but that is also non-tender. Now the answer becomes yes, all of you have answered correctly. That is syphilis. That is painless lymphadenopathy, painless genital ulcer. So you can very easily remember it is syphilis, that is syphilis. And why it is not donovenosis? Because in donovenosis, no lymphadenopathy is seen. So here it is mentioned that lymph nodes are enlarged, but no lymphadenopathy is seen in donovenosis. So that's why donovenosis is also not the answer. And if there are swellings present in inguinal areas in a case of donovenosis, that is not lymph nodes, but what we call them? We call them pseudobubos. So pseudobubos are seen in donovenosis. Okay. So remember, these are few characteristics of these genital ulcers which will help you remember in the examination. If they ask you about syphilis, remember less, that is painless genital ulcer, very hard genital ulcer, and in that genital ulcer, lymph nodes can be enlarged and they are generally bilateral, non-tender, rubbery lymphadenopathy. Then LGB genital ulcers are generally transient. For chancroid, the genital ulcers are painless and they are multiple with undermined edges. And in donovenosis, no lymphadenopathy is seen. And the base of the genital ulcer in donovenosis is beefy red base, which bleeds very easily on touch. So if these points are written, then you can choose donovenosis. But here the answer is syphilis. Now moving to the third question, the next question, that is a patient presented with an itchy lesion. Okay, so there is itching present in the lesions and the lesions are as shown in the image below. Now, if you look at the image, you can see that over the wrist of the patient, there are few lesions. All these lesions are very small. They are papules. They are not very big lesions like psoriasis. They are very small lesions and they are slightly purplish in color. So they are purple, they are papules, and they are itching, that is pruritic. So already you can see that there are three P's which are present: papule, purple, pruritic. If you look at the shape is not exactly round but slightly polygonal. So it is polygonal in shape. So, and if you look at, they are flat surfaced, all these lesions are flat, so they are plain topped. So these are the 5 P's of lichen planus. Yes, so this is lichen planus where plain purple polygonal pruritic papules are seen. Okay, now remember that why this is not scabies. This is not scabies because scabies is itchy, but there the wrist can be involved, that is a flexural area, but there the dorsum of the foot, such type of lesions are not seen. They are not plain topped. They are not purple in color. Commonly, circle of Hebra is involved and nocturnal pruritus is seen. Some family history might be mentioned that the other family members are also suffering from the disease. Then you should think of scabies. Why it is not psoriasis? Because in psoriasis, very large lesions, that is plaques, are seen with silvery white scaling, which is missing here. And why these are not warts? Because warts are very rough surface, they are verrucous. So generally the warts are rough surface, but here they are plain top. Okay, so these are the lesions of lichen planus. Another important point is that in warts sometimes the plain warts can be seen, but these are not plain warts. Why? Because they are having the characteristics of lichen planus, that is they are purplish in color, they are polygonal in shape. So that's why the answer is lichen planus. So lichen planus is another important topic for your exam. So remember the 8 P's of lichen planus. I have already told you 5 P's, that is plain, purple, polygonal, pruritic, papules. So 5 P's I have already told you. Remember few more P's, and that is pterygium is seen. That is the nail finding of lichen planus. A pattern is seen over buccal mucosa, that is white lacy pattern, and the pila, that is the hair follicle get involved because patient have hair loss, that is scarring alopecia. So you can very easily remember 8 P's of lichen planus. अभी तक आपने गाइड्स में पढ़े होंगे 5 P's, लेकिन आज आप याद कर लीजिए कितने P's? 8 P's. So 5 P's in the skin: plain, purple, polygonal, pruritic papules, pterygium over nail, pattern over buccal mucosa, and pila, that is hair loss leading to scarring alopecia. Moving to the next question, here they are saying that a 45-year-old smoker presented to the hospital with a painless oral lesion. So oral lesions are shown. Yes, so Santosh Kumar is writing that in scabies, burrows are seen. Very important point. Already a question have been asked. So burrows are seen in scabies. If burrows are mentioned, nocturnal pruritus, that is itching at night, or if family history is mentioned, then you should suspect scabies. Now, painless oral lesion as shown in the image, and you can see which site is involved. The lateral part of the tongue is involved. This white patch develops over the oral cavity given in the image below. What is the diagnosis? So some students get confused with candidiasis, but this is not candidiasis. Why it is not candidiasis? Because the most common type of candidiasis is known as oropharyngeal candidiasis or acute pseudomembranous candidiasis, where buccal mucosa or the pharynx develops a white membrane, and this white membrane, when rubbed, can be detached. So this is the feature which is seen in candidiasis, where the white membrane is not localized to just the lateral part of the tongue, but it can involve the buccal mucosa. Over the pharynges it might be present. If you rub, it can be detached, and generally it have some or the other symptoms associated. So patient आकर कुछ complain भी करेगा कि डॉक्टर साहब जब भी मैं खाना खाता हूं तो बहुत मिर्च मसाला लगता है, या फिर there is some discomfort which is associated, but here it is painless, and painless points towards leukoplakia, which is caused by Epstein-Barr virus known as oral hairy leukoplakia, which generally involves the lateral part of the tongue as shown here. And This is oral hairy leukoplakia, and this cannot be detached. So if you rub it, it can't be scrapped off. So very nice. So Bhuvana is telling that candidiasis can be scrapped off, it can be detached, but this cannot be detached. So this is a case of leukoplakia. Why it is not lichen planus? Just now I told you that in lichen planus, a pattern is seen over buccal mucosa, but remember that that pattern which is seen over buccal mucosa is generally lacy pattern or reticulate pattern. So it is sometimes like this, lacy, or it can be reticulate, something like this. So it is reticulate or lacy pattern generally seen over the buccal mucosa, and oral cancers, oral cancer are generally like if there is a squamous cell carcinoma or some oral cancer associated, there can be an exophytic growth and not necessarily just a white membrane. So that's why this is a case of leukoplakia. So remember that if asymptomatic, that is painless white patch is present which cannot be detached and present over the lateral part of the tongue here, then you should mark leukoplakia. But if it is involving the oral mucosa, pharynges, and there is some predisposing factor associated, like candidiasis is generally associated with diabetes, or sometimes an immunocompromised patient like HIV patient, or if the membrane can be detached as mentioned, then mark candidiasis. Moving to the next question, a 25-year-old patient presented to the OPD with a history of prolonged use of steroids. So patient have a history of prolonged use of steroids. All of you know steroids are immunosuppressive agents. They are anti-inflammatory agents. They reduce the inflammation, and that's why a patient complains of a rash that has become less red, less itchy using steroids. So patient developed a skin rash, and when he started applying steroid, it becomes less red, less itchy. On examination, there are well-defined, slightly raised erythematous plaque with central clearing. Very important point. So many times I have told in my classes that central clearing is feature of tinea. So the answer is tinea. And if you look at the options, all the options are also having tinea. So the answer is tinea. Now the question is that you have to tell me that this is which tinea. And the tinea which develops after steroid application is known as hidden tinea or tinea incognito. I hope all of you remember tinea incognito. Okay, so this is hidden tinea. This is not clearly visible. Why it is not clearly visible? Because the patient is applying steroids, due to which it is less red, it is less itchy, and this is known as tinea incognito. So all these points are pointing towards tinea, but this is not any other type of tinea. This is tinea incognito because the patient is applying steroids. Now remember that if in the question, instead of central clearing, central scarring is written, then what you will mark? And if central crusting is written, then what you will mark? So if central scarring is written, mark answer as lupus vulgaris. Lupus vulgaris is the most common type of skin tuberculosis, while central crusting is feature of leishmaniasis. It is feature of leishmaniasis. Okay. So this question was very recently asked in your screening exam. So this is a previous year question, and this was asked in your screening exam, tinea incognito. So remember that tinea corporis, tinea cruris, tinea pedis depends on the site. When it involves the foot, we call it tinea pedis. When it involves the groin, that is tinea cruris. And if body is involved, then it is tinea corporis. But tinea incognito, if the patient is applying steroids. So because steroid is written here, answer is tinea tinea incognito. Let us complete the question. And a scaly border with various part of the body. What is the probable cause for the above scenario? So this is a case of tinea incognito. Okay, so remember this occurs after steroid application. Moving to the next question, again a very important question. So many times question have been asked recently in your screening exam. Also this question came, especially they asked the treatment for this condition. So identify the condition shown in the image below. What you can see that in the groin of the patient, in the genital area of the patient is developing a very rough, warty growth. These are anogenital warts. Anogenital warts are also known as condyloma acuminata. So this is a case of condyloma acuminata caused by human papilloma virus 6 and 11. If both come in separate options, choose 6. So it is caused by human papilloma virus 6 and 11. This is a case of anogenital warts or condyloma acuminata. Now, why this is not Bowen's disease? Because Bowen's disease is a pre-malignant condition, that is carcinoma in situ, which generally occur over sun-exposed areas. So it commonly occurs over sun-exposed areas. Why it is not condyloma lata? Because condyloma lata are seen in secondary syphilis, and they are also present in groin, but they are flat topped. So they are not rough or verrucous. Here you can see these are very rough growths, but these are generally flat growths or plain growths. These are seen in secondary syphilis. These are condyloma lata. While these are not hemorrhoids, you must have read in surgery, hemorrhoids are not rough surfaced, and there is always a history of bleeding which is associated. So that history if written, then you can suspect hemorrhoids. They are generally smooth surface, they are not rough surface. So this is a case of warts. Now another important question which was recently asked in your screening exam, that what is the treatment of condyloma acuminata? Treatment. So treatment of anogenital warts is imiquimod. Imiquimod is a topical agent which is asked to apply over the lesions. If imiquimod is not there, you can choose podophylotoxin. But both these are teratogenic. So that's why we never use in pregnancy. And this was the question which was asked, that in pregnant patient suffering from condyloma acuminata, what will be the treatment? Answer is cryotherapy. So remember, if pregnancy is not mentioned, then choose imiquimod. If pregnancy is mentioned, then choose cryotherapy. That is, we apply liquid nitrogen over the lesions. Okay. So I hope you recall how many of you have attempted the last exam. If you have attempted that exam, you must be knowing that this question came. That is, what is the treatment of condyloma acuminata in a pregnant patient? Answer was cryotherapy. So this is a very important topic, and again this question can come in your exam. Moving to the next question, which was also recently asked in your exam, and that was based on mycobacterial infection caused by Mycobacterium leprae, that is leprosy. Now here is the question, a woman who is already on multi-drug therapy. So all of you know that what is the treatment for leprosy? The treatment for leprosy is MDT, multi-drug therapy, where we use 3 drugs, rifampicin, clofazimine, and dapsone. So patient was started on multi-drug therapy, and the patient presented with type 2 lepra reaction. So sometimes when we start treatment in a case of leprosy, they might develop type 2 lepra reaction, which is also known as ENL reaction. Why we call it ENL? Because in these cases, some new lesions start developing. These new lesions, which start developing over the skin, are known as erythema nodosum leprosum, that is E, N, and L. So E, N, L start developing. What is the treatment of choice for this patient? So because the patient is suffering from leprosy, we will continue MDT. Okay, so no point of stopping MDT. In leprosy, we will continue MDT. Now, along with continuing MDT, you have to give treatment for lepra reaction, and the drug of choice for lepra reaction or ENL reaction is oral steroids and not antibiotics. We will continue MDT and add oral steroids. But remember that in type 2 lepra reaction, steroids is the drug of choice. This is the drug of choice. But if drug of choice, that is steroid, is not mentioned, then you can also choose thalidomide, which is effective in type 2 but not effective in type 1. So thalidomide can also be used. Okay, but this is not drug of choice. So remember, the first choice answer will be D, that is continue MDT and add oral steroids. But if steroid is not there in the option, then you can choose thalidomide. But thalidomide is not the drug of choice because there is one side effect of thalidomide. It is teratogenic. So it is teratogenic drug. Yes, so Sachin Rajput is saying rule of 5 lepra reaction. Very nice. So rule of 5 is that is type 1 lepra reaction is type 4 hypersensitivity and type 2 lepra reaction is type 3 hypersensitivity. So 1 plus 4 is 5 and 2 plus 3 is 5. Very good. Sai Priya is saying that erythema nodosum. So remember, don't get confused with erythema nodosum. Erythema nodosum is different and erythema nodosum leprosum is different. Erythema nodosum leprosum is seen in leprosy. It is a type of lepra reaction, while erythema nodosum have multiple causes. It can be idiopathic. It can be due to certain infections like streptococcal infection, and there generally red nodular swellings are seen over the anterior part of the leg. So their shin involvement is seen. So don't get confused. Cypria, erythema nodosum is seen over the anterior part of the leg, while here it can develop anywhere over the body. This is associated with leprosy, while those are generally associated with other conditions. I already gave you the name of the conditions like erythema nodosum. So some students are confusing with erythema nodosum. So I gave you a mnemonic that you can very easily remember the causes of erythema nodosum by just remembering this word nodosum. Okay, so it can be associated with drugs like oral contraceptive pills, streptococcal infection, ulcerative colitis, and maternity, that is pregnancy. So this is erythema nodosum. It occurs over anterior part of the leg, that is shin. Okay, so don't get confused. This is EN and here we are talking about ENL. Okay, that is leprosum. I hope this is clear. The next question is that match the following types of scales which with their associated conditions. So just now I told you that collar-like collarate scales, again very important question, is seen associated with pityriasis rosea. It is seen with pityriasis rosea. Silvery white scales are seen in psoriasis. So first B and 2C. Then mica-like scales are seen in pityriasis lichenoides chronica, and brany scales are seen in pityriasis versicolor. Okay, so these are very important scales. Already questions have been asked. So remember, collarate of scales are seen in rosea, pityriasis rosea. While silvery white scales are seen in psoriasis, mica-like scales are seen in pityriasis lichenoides chronica, and brany scales are seen in pityriasis versicolor. Here, bran means bhusa. Bhusa, that is very fine, like powder. So bran-like or powder-like, that is powdery scales, are feature of versicolor. So these scales are very important, and sometimes questions are asked on these scales, like fish-like scales are seen in. Yes. So who will tell me fish-like scales are seen in which condition? Yes, type your answer. Fish-like scales are seen in. So fish-like scales are seen in. Yes, so Sahana is telling, yes, very important point. Sahana is telling that if you do investigation in pityriasis versicolor, that is 10% KOH mount, which finding is seen? Yes, spaghetti and meatball appearance is seen. Spaghetti and meatball appearance is seen in pityriasis versicolor. Very good. And Dr. Sachin Rajput have answered this correctly, that fish-like scales are seen in ichthyosis. Ichthyosis. So ichthyo means fish. So very easy to remember. Ichthyo means fish. So fish-like scales are seen in ichthyosis. Very good. So Santosh Kumar have also answered this correctly. Status Gallery, Dr. Than, all of you have answered correctly. Another repeat question, already question have been asked in your screening exam. A 41-year-old patient presented with lesion shown in the image below. And what you can see in the lesion? In the lesion, you can see that the lesions are only on one side. That is, they are unilateral. They are small fluid-filled lesions. So they are vesicles. They are along a particular nerve segment. So they are segmental. Segmental, that is dermatomal. That is, they are involving a dermatome. And very important point or very important clue is that patient describes having a sensation of spiders crawling in the area of the lesion. तो पेशेंट को पेन होता है और कैसा पेन होता है? ऐसा पेन होता है जैसे कि वहां पर स्पाइडर्स चल रहे हो. Okay, this is known as paresthesia. So there is paresthesia, a feeling of spider crawling, or sometimes even when the clothes touch that area, the patient have the strong sensation of pain, that is, or burning sensation. That is a very characteristic feature of herpes zoster. Yes, herpes zoster infection, which is due to reactivation of varicella zoster virus. So it is due to reactivation of varicella zoster virus. Herpes simplex can be HSV1 or HSV2. HSV1 generally causes herpes labialis, so this develops generally around lips, while HSV2 causes genitalis, which occurs over genitals. While irritant and allergic dermatitis are due to contact to something, like the most common irritant which causes irritant dermatitis is detergents. And the most common allergen which causes allergic dermatitis is nickel. So these are some important clues which take you to the answer. So the most common irritant is which causes irritant contact dermatitis is detergents, and the most common allergen which causes allergic contact dermatitis is nickel, which is present in artificial ornaments or jewelry. Some patients also develop allergic contact dermatitis to cement. Okay, so allergic contact dermatitis to cement is due to a chemical present in cement, and that is potassium dichromate. Or sometimes in option they simply write chromate. So due to chromate or potassium dichromate, the patient start developing dermatitis over their hands, especially the workers who come in contact with cement. So these are the common allergens which cause it. Yes, very nice. Hemant Roy is writing that in the Suraksha clinic, if you are using narco kits, and the patient of STI, that is herpes genitalis, comes to you, which kit you will give? So remember that the drug of choice for herpes infection, whether it is zoster or whether it is herpes simplex virus infection, that is genitalis or labialis, the drug of choice is acyclovir. So in Suraksha clinic, which is STI clinic, generally the patient of herpes genitalis come, and there we use which kit? Red kit. That is kit number 5. So kit number 5, red kit, have acyclovir. So that's why we give acyclovir and herpes genitalis in the Suraksha clinic. Very good. Suraksha clinic, that is syndromic management of STI is done. So the acyclovir is the drug of choice. Somebody is asking what is the treatment for dermatitis. So dermatitis is treated with, depending on the severity. So if it is mild, you can treat with topical steroids. You can give tacrolimus, and you can use oral agents as well, like oral steroids. In airborne contact dermatitis, we generally prefer azathioprine. So these are the treatments which can be used. Moving to the next question. This is slightly difficult. Let me see if you can answer it correctly. Tell me in your chat box, write the name of the condition. So tell me the name of the condition the patient is suffering from. So 8-year-old boy presented to the OPD with weakness in the lower limbs. So patient is having weakness in the lower limbs and the rash over the eyelids. So around eyelids there is rash and the patient is having weakness in the lower limbs. The biopsy shows inflammation of the muscle. So there is muscle inflammation. So Sachin Rajput is sharing his experience that, sir, I skipped last time Dharma without touching it and missed 3 marks. Now only your way of teaching, I get good command on Dharma by grace of God. So Sachin, you are very true that many students do this very important mistake which they should avoid, and that is skipping a subject, especially a short subject which takes hardly 1 day to revise. Okay, so skipping a short subject is a very bad thing to do, because these are highly scoring subjects, and if you can just within a period of like 6 hours or 12 hours or within 1 day, if you can revise one subject and get 3 or 5 marks, then that is a wonderful thing to do. So I would suggest all of you never skip any subject, especially the short subject. You should always do them, and because they take less time, their name is short subject का नाम ही है short subject, तो उसमें बहुत short time लगता है, तो शॉर्ट टाइम में ज्यादा मार्क्स आप ला सकते हो अगर आप शॉर्ट सब्जेक्ट करके जाते हो। तो कभी भी मिस मत करो इन सब्जेक्ट को। और स्पेशली आपने अगर मेरी क्लास अटेंड की है, इफ यू हैव अटेंडेड माय क्लास, देन आई हैव मेड दिस डर्मेटोलॉजी so easy that you can revise within 3 hours. Okay, I have given you a rapid revision also, 3 hours rapid revision. Even you can revise in 2 hours. So in 2 hours you can get 3 to 5 marks, and that is a wonderful thing which you can do for yourself. Okay, so I hope you will not repeat this mistake. So biopsy shows inflammation of the muscle. What is the finding shown in the image below? So yes, many of you have answered correctly. Very good. Very good. Bhuvana, Saroj, Bholenath, Kajal, everybody have answered this correctly. Medico 365, Sachin Rajput. It is a case of dermatomyositis. Yes, myositis means inflammation of the muscles. So it is written here. And dermo, why? Because it is associated with dermatological features. And the feature shown in the image below is it is present over knuckles, and over knuckles which papules are present? Grotton's papules are present. So answer is A. But they have mentioned that there is a rash over eyelid, and this rash over eyelid is known as heliotrope rash. So heliotrope rash is the one which is present around eyelids, but here they are asking that what is the finding shown in the image below. In the image, knuckles are involved, so that's why the answer is Grotton's papules. Shawl shine is the pigmentation which is seen over the shoulder or the back area, upper back or shoulder area where we wear shawl. So this is generally seen over upper back. While scleroderma is not related to dermatomyositis, it is a separate condition where there is bounding down of the skin and there is salt pepper pigmentation. In scleroderma, salt pepper pigmentation is seen. And why we call it salt pepper? Because salt is white and pepper is black. So when you will see the skin of these patients, you will get white and black dots alternatively. So because a lot of white and black dots are seen, we call it salt pepper pigmentation. So Ajay Kumar is surprised and he's asking only 3-hour revision. Yes, only 3-hour revision is required. I have already given the rapid revision, the very quick revision you can do in hardly 2 to 3 hours. Okay, so don't worry about the revision. If you have attended my revision, you can definitely do it. So these are Grotton's papules seen in dermatomyositis. Very good. I was expecting that maybe you will not be able to answer, but most of you have answered this question correctly. I'm very happy that you are doing your preparation well. Now, the next question is that 35-year-old female presented with body mass index of 30. Okay, so BMI बहुत ज़्यादा है. BMI ज़्यादा मतलब height कम, weight ज़्यादा, because BMI is weight upon height in meter square. ओके, सो अगर किसी की हाइट कम है और वेट ज्यादा है तो क्या हो जाता है? बीएमआई बढ़ जाता है, मतलब वेट बढ़ने से बीएमआई बढ़ जाता है। तो पेशेंट बहुत ओबीज है और पेशेंट के नेक पर क्या हो रहा है? एक डार्क कलर का पिगमेंटेशन। सो पेशेंट इज डेवलपिंग अ डार्क वेलवेटी पिगमेंटेशन ओवर नेक फोल्ड। दिस इज अ केस ऑफ acanthosis nigricans. And acanthosis nigricans is seen associated with obesity, and obesity, especially the central obesity, is a feature of metabolic syndrome, and that's why the answer here is metabolic syndrome. So remember that obesity is the most common cause of acanthosis nigricans, though it can be seen associated with other causes of obesity as well as other causes of insulin resistance, and that's why it is seen associated with diabetes mellitus, acanthosis, this metabolic syndrome. So all these conditions can be seen as an underlying cause for acanthosis nigricans. Okay, so this is a case of acanthosis nigricans. Acanthosis nigricans only occurs over neck? No, it can occur over any fold. So generally it involves folds like axilla, groin, neck folds. Moving to the next question, a 40-year-old woman presented with hair loss. So patient is having a lot of hair loss for the past 3 months. So hair loss since past 3 months. She have history of COVID 8 months back. So 8 months back, there was fever, COVID fever, 8 months back. And since 3 months, she is having lot of hair loss. Okay, so when excessive hair loss starts after some predisposing factor like fever, pregnancy, typhoid fever, COVID infection, that is known as telogen effluvium. And telogen effluvium generally starts after 3 months. Why? Because the telogen phase lasts for 3 months. So here also it have started after 3 months, like 3 to 5 months it can start. So this is a case of telogen effluvium. Why it is not tinea capitis? Because commonly tinea capitis presents with carrion, and in carrion swelling is seen, but here no swelling is present, so that's why it is not tinea capitis. This is not trichotillomania because the patient is psychiatric and patient have tendency to pull the hair follicle. No such history is mentioned here. And this is not female pattern androgenetic alopecia. Why? Because it is not related to any fever or something. Telogen effluvium is associated with fever like typhoid fever or COVID fever. So that's why the answer is telogen effluvium. Yes, rule of 3. So this also I told you in my class. 3 hair cycle have 3 stages: anagen, catagen, telogen, and these phases last for 3 years, 3 weeks, and 3 months. So you can very easily remember these points. 3, 3, 3. Anagen, catagen, telogen. This is for 3 years. This is for 3 weeks. This is for 3 months. Very good. Now, this is a very classical case. Just by looking at the image, you can answer it, because all of you must have seen this question, this image, and it was asked in your screening exam as well. The answer of this question is yes, Madura foot or mycetoma. Madura foot or mycetoma. Why? Because here there is tumefaction. Tumefaction, that is multiple swellings with multiple sinuses and discharge. And the most common site is foot. So this is a case of Madura foot or mycetoma. Why it is not chromoblastomycosis? Because chromoblastomycosis generally presents with verrucous, that is rough growths, but this is not rough. These are multiple swellings. Similarly, it is not tuberculosis. Why? Tuberculosis generally presents with central scarring, and this tuberculosis verrucosa cutis generally presents with verrucous or wart-like growth, which is missing here. And this is not cellulitis. Why? Because cellulitis generally presents with a lot of swelling, inflammation, warm skin, which is missing here. So this is a case of Madura foot, that is mycetoma, which can be eumycetoma or actinomycetoma, depending on the causative agent, whether it is fungus or bacterial. Yes, so Sachin Rajput is answering very nicely that chromoblastomycosis, one very important point in chromoblastomycosis is copper penny bodies. Copper penny bodies. So copper penny bodies are seen. Very good. So copper penny bodies are seen in chromoblastomycosis. C for C. And tuberculosis verrucosa cutis presents with wart-like lesions. So it is also known as anatomist wart. Anatomist wart, very commonly seen in anatomy professors. So this is anatomist wart, that is TBVC, tuberculosis verrucosa cutis. सो इसी बीच फुटबॉल मेनिया ने बोला है सर के वीडियो को लाइक ठोको, तो ठोको ठोको ठोको, लाइक ठोको, शेयर, सब्सक्राइब, so that more students can benefit from it. सचिन राजपूत, लाइक रुकने नहीं चाहिए, बहुत अच्छा। So let us move on to the next question. All are seen in the condition except. So this is very important thing to remember in the examination. कई बार हम क्वेश्चन पढ़ते हैं और एक्सेप्ट पढ़ना भूल जाते हैं और वहीं पर हमें आता हुआ क्वेश्चन रॉन्ग हो जाता है, ठीक है। सो एक्सेप्ट का बहुत महत्व होता है एग्जाम में। हम पूरा क्वेश्चन पढ़ते हैं और लास्ट में एक्सेप्ट पढ़ना भूल गए तो आपका आंसर डेफिनेटली रॉन्ग हो जाएगा। So remember to read except, very important point. Okay, so all are seen in the condition except. So now in this you can see that this very dark colored lesion, that is purplish colored lesion. So these are the 5 P's of lichen planus, that is these are plain purple polygonal pruritic papules, and these are seen in lichen planus. And there are 3 features of lichen planus which are mentioned here, that is Wickham striae, saw-toothed appearance, and severity bodies. All these are seen in lichen planus except for Munro's microabscess, which is seen in psoriasis. This is seen in psoriasis. So answer here is Munro's microabscess. So remember Munro's microabscess and Kogo's pustules. Sai Priya is asking Kogo's pustules. Yes. So Munro's microabscess and Kogo's pustules, both these are seen in psoriasis. But Wickham striae is the reticulate pattern which is seen in lichen planus. Saw-toothed acanthosis, that is saw-tooth-like rete ridges are seen. So if this is epidermis, this is dermis. Normally rete ridges are something like this, but here in lichen planus they appear something like this, that is they are pointed like a sawtooth. So saw-toothed rete ridges and severity bodies, these are also seen in lichen planus. So remember all these are important. All these can be seen in lichen planus. So 3 features of lichen planus except, answer becomes A, Munro's microabscess, which are seen in psoriasis. Now let us revise few microabscesses here. Munro's microabscess are seen in psoriasis, and Poutrier's microabscess are seen in mycosis fungoides. And one more, papillary tip microabscess are seen in dermatitis herpetiformis. So these are 3 very important microabscesses to remember. First, Munro's seen in psoriasis, Poutrier's seen in mycosis fungoides, and papillary tip microabscess seen in dermatitis herpetiformis. और मैंने आपका इसका एक निमोनिक भी बताया था। निमोनिक बहुत ही इजी है, M is seen in P and P is seen in M. So Munro's in psoriasis and P, Poutrier's in mycosis fungoides. अब आ जाते हैं नेक्स्ट क्वेश्चन पर। नेक्स्ट क्वेश्चन इज a patient presented with below lesions on the first visit. So below lesions are seen. Now you can see 2 images. Okay, first image is showing skin lesions which are present over the scalp. These are red in color, they are erythematous and they are having scaling, as you can see, and the scaling is slightly white. So silvery white scaling is present. She later developed arthritis. So स्किन लीजन तो सोरियासिस जैसे लग रहे हैं और साथ में है आर्थराइटिस। आर्थराइटिस हो सकता है सोरियासिस में, हाँ हो सकता है। विच टाइप ऑफ आर्थराइटिस? सोरियाटिक आर्थराइटिस। विच जॉइंट इज कॉमनली इन्वॉल्व्ड? DIP. So distal interphalangeal joint is commonly involved. As is shown in the image. So this is a case of psoriasis with psoriatic arthritis. What is the treatment? So I told you, what is the treatment for psoriatic arthritis? Yes, it is methotrexate. So methotrexate is the drug of choice for psoriatic arthritis as well as erythrodermic psoriasis. So answer becomes methotrexate. This acitretin is the drug of choice for pustular psoriasis. So for pustular psoriasis, it is acitretin. Rituximab is used in pemphigus. It is used in pemphigus. Cyclophosphamide is also used in pemphigus. So cyclophosphamide, rituximab, they are generally used in pemphigus. Methotrexate and acitretin are used in psoriasis, where methotrexate is the drug of choice for psoriatic arthritis. So that's why the answer is methotrexate. And Hemant Roy have pointed out very correctly that if in this joint, that is DIP joint of psoriatic arthritis, if you do X-ray, what finding is seen? Pencil in cup deformity. Very good. Pencil in cup deformity. And Cypriya is telling rituximab is monoclonal antibody. Correct. Which monoclonal antibody? Anti-CD20. So it is anti-CD20. Guttate psoriasis, Bhovana is saying, yes, there is one variant known as guttate psoriasis, which is due to upper respiratory tract infection. And there we treat with erythromycin, which is antibiotic. Very good. Now here, this sign is shown in the given picture. And what you can see in this sign that there are linear lesions which are present. So do you know any sign or condition where when we scratch the condition, multiple lesions start developing along the line of scratch or along the line of trauma? That is known as Koebner's phenomena or isomorphic phenomena. This is true Koebner's phenomena, which is seen in psoriasis, vitiligo, and lichen planus. Now, other options mentioned here are also very important. So remember, Auspit sign is seen in psoriasis. That is, when we scrap the lesions of psoriasis, the end result is pinpoint bleeding. That is known as Auspit sign. Dermographism is seen in urticaria, where wheals develop. These are transient lesions for a very short duration. And Derriere sign is seen in urticaria pigmentosa, which is a type of cutaneous mastocytosis. So already these questions have been asked. So remember, Derriere sign is also very important question. Derriere sign. So Derriere sign is seen in urticaria pigmentosa, that is cutaneous mastocytosis. Then Auspit sign is seen in psoriasis, and Koebner's phenomena or isomorphic phenomena, which is true, is seen in psoriasis, vitiligo, and lichen planus. But if false is written, false Koebner's, then it is seen in warts and molluscum contagiosum. Very good. So answer is C, Koebner's phenomenon. Moving to the next question, a truck driver presents with non-pruritic lesions all over the body. So they are non-itchy lesions. Patient is a truck driver, including palms and oral ulcers are also present. What is the probable diagnosis? So remember that truck drivers, because most of the time they are outside their homes and they are taking a truck from one place to another, so they are driving for a very long period, sometimes months together. So they have more chances to develop sexually transmitted infection because they have multiple sexual partners. Okay, so whenever truck drivers is mentioned, generally it is a case of STI. And in this case, you can see that non-pruritic rashes are present over palm, as you can see here. And in these rashes, you can elicit one sign, and that is known as Buschke-Ollendorff sign. Where if you press the lesion with a glass, if you press the lesion with a blunt object or head end of the Alpin, there is deep dermal tenderness. This is known as Buschke-Ollendorff sign, which is seen in secondary syphilis. So this is a case of secondary syphilis. This is not drug eruption. Why? Because any drug history is not mentioned. This is not TEN or Steven-Johnson syndrome, because these are also generally associated with drugs like anti-epileptic drugs. So because no drug history is mentioned, these are not the answer. The answer is secondary syphilis, which presents with rashes over body, including palm and sole, which can be dark in color, and when pressed, they have one deep dermal tenderness. This is known as which sign? Buschke-Ollendorff sign. Moving to the next question. 35-year-old female patient developed vesicobullous disorder. So here vesicobullous lesions are present, that is fluid-filled lesions are present, which shows fish net-like appearance. Very important finding. Fish net-like pattern is seen in. So on DIF, direct immunofluorescence, fish net-like pattern was seen. A diagnosis of pemphigus vulgaris was made. Which among the following describes the disease? So they have already given the diagnosis. You have to identify the correct option. Autoimmune disorder where antibodies are formed against hemidesmosomes? No, they are formed against desmosomes. That is desmoglin. Autoimmune disorder with anti-conexin antibodies? No. Disease with poorly formed cell adhesion molecules? Disease with poorly formed cell adhesion molecules? No, here cell adhesion molecules are not purely formed. Actually, they are destroyed because of the antibodies formed. This is an autoimmune disorder where antibodies are formed against desmosomes. Yes. Which desmosome? Desmoglin. So this is the correct answer. Okay. So desmoglin is not poorly formed. Desmoglin is perfect. So C is not the answer. Actually, antibodies are formed against it. That is the etiology. And that's why the answer is D. So remember, pemphigus vulgaris, very important. Pemphigus vulgaris, desmoglin 3 more than desmoglin 1 involvement. Pemphigus foliaceus, desmoglin 1 involvement. Row of tombstones appearance is seen and fish net-like pattern is seen. There is one sign which is seen in pemphigus. Which sign? Nikolsky sign. So all these are the important features which you can remember. Tombstones. Moving to the next question, a male child with mild painful swelling in the scalp. So there is swelling in the scalp and this is mild painful, that is there is tenderness. Since 3 months, the patient has dog pat at home. What is the diagnosis? Okay, so swelling over scalp. So if a child, because child are more prone to develop tinea capitis. So this condition is more common in children. And these children present with tender swelling over scalp. So tender, mild pain, not very painful. So this is not folliculitis because folliculitis is very painful. This is mild painful. So that's why this is not abscess of folliculitis. And sebaceous cysts are generally asymptomatic. So this is a case of tinea capitis, that is carrion, where swelling is present. And that's why the answer is carrion. Now, what is the importance of dog pet at home? Dog pet at home means आपने microbiology में पढ़ा होगा कि these dermatophytes, they can be anthropophilic, zoophilic, zeophilic. Okay, so anthropophilic, that is transmitting from man to man, geophilic transmitting from soil to man, and zoophilic transmitting from animal to man. So zoophilic generally cause inflammation and generally cause carrion. So these are zoophilic species which have come from the dog to the child, and that's why this has caused this painful swelling over scalp. So this is a case of carrion. And remember, in carrion, the drug of choice is griseofulvin. Griseofulvin is the drug of choice. Okay, so very important question. Already question have been asked on carrion, so remember this point. Then 1-year-old child presented with eczematous dermatitis over face. His mother has history of bronchial asthma. What is the probable diagnosis? So all of you know that patient is having dermatitis, and which dermatitis is associated with family history of asthma or atopy? It is atopic dermatitis. So answer here is atopic dermatitis, and atopic dermatitis generally involves flexures in adults, but in children it can involve face as well as extensors when they crawl. So here face having this dermatitis and the mother is having history of atopy or asthma. This is a very important clue, and this is a very itchy condition. This is a case of atopic dermatitis. Airborne contact dermatitis is generally due to Parthenium, which is a plant. Seborrheic dermatitis, I already told you, in infants is known as cradle cap, and this generally occurs over scalp. And infective eczematous dermatitis is having infection, so there will be pus-filled lesions. So this is a case of atopic dermatitis. Now, all of the following are not true with respect to erythema multiforme except. So again, see, not true except. Okay, so this is very confusing in the exam. So not true means false. Okay, true means true, not true means false, and false and except means they are asking true. Okay, so not and except will be will get removed, and they are asking the true statement. Okay, so don't get confused when not and except is written. So they are asking the true statement about erythema multiforme, and we know in erythema multiforme, targetoid lesions or target-like lesions are seen. Okay, so such target-like lesions are seen in erythema multiforme. So that's why the answer is A. Now remember that most common is due to leukemia. No, it is most commonly due to viral infection. Sometimes it can be due to drugs. And because it is due to viral infection, generally steroids are avoided. Okay, because in any infection, if you give steroids, it can aggravate. So steroid is not the drug of choice. And Kobnus phenomena, we have already written. Kobnus phenomena is seen in psoriasis, lichen planus, vitiligo. It is not seen in erythema multiforme. So that's why the answer is A. A, that is target-like lesions are seen because they have multiple concentric rings. I hope this is clear. So leukemia is not the cause. Most common cause is viral infection, commonly herpes simplex virus infection. So target lesions is also very important. Already questions have been asked on target lesions. Which virus Arvind is asking? It is herpes simplex virus commonly associated. बिल्कुल सही सचिन राजपूत एनबीई ऐसे ही फंसाती है कभी लिख देती है ट्रू कभी लिख देती है नॉट ट्रू कभी लिख देती है नॉट ट्रू एंड एक्सेप्ट okay so don't get confused read it very carefully even if you know the answer sometimes you mark it wrong a lesion was seen on the face of a 42-year-old patient as shown below which of the following would be the ideal management of the condition now if you look at this image you can see this erythematous lesion which is only present over the face that is the exposed area and there is lot of scarring present. So central scarring is feature of, it is feature of lupus vulgaris. Okay, so remember that lupus vulgaris is a very slowly growing lesion with central scarring. If you get scarring in the center, this is not leprosy. Some of the students are writing D. This is not leprosy. Why? Because whenever they talk about leprosy, they will mention that there is loss of sensation, nerves are involved. So no such thing is mentioned here. So nerves are not mentioned. Any anesthesia is not mentioned. Any sensory loss is not mentioned. Any hypoanesthetic patch or hypopigmented patch is not mentioned. So this is not leprosy. Okay, this is lupus vulgaris, which is the most common type of tuberculosis, skin tuberculosis, and that's why we give ATT, anti-tubercular therapy. Retinoids and steroids are not used in lupus vulgaris. So you can identify this lesion. If the lesion is slowly growing, it is persisting there for a long period. Tuberculosis generally occur over exposed areas like face, and there is scarring present in the center, then you should suspect lupus vulgaris. Then a patient with a known case of tuberculosis has been taken multiple medication. Okay, so patient is taking multiple medications. Now he presented as shown in the image below. In the image, you can see a lot of skin is involved and there is epidermal separation which is taking place. There is hemorrhagic skin which is present. So epidermal separation. And you can see that almost whole skin is appearing as if it is involved. So more than 30% of the skin. Patient is taking multiple medications. So there is drug history associated. And you can see oral mucosa or the lip area is also involved. So there is crusting present around the lips. So all these are pointing towards more than 30% of the skin is involved. All these are pointing towards 10, toxic epidermal necrolysis. If less area is involved, then you can choose SJS. Okay, and this is not fixed drug eruption because fixed drug eruption occur over one particular site. Every time patient take the drug, same lesions develop over same site. And anaphylaxis is very severe and it can lead to airway blockage and all. But here, all those things are not associated. Skin features are present where a lot of epidermal separation is occurring. So this is a case of 10. Which sign you can elicit in this case? Nikolsky sign. Because the skin is separating, if you apply pressure, it will further separate. So all these points are pointing towards 10, that is toxic epidermal necrolysis. So you can see this image. This is, if similar image comes in your exam, identify the condition. It is 10, generally associated with anti-epileptic drugs. So some drug history is always mentioned in the question. So with this, we come to the last question for today's discussion. And that question is this. This is also a repeat question. Already question have been asked in your exam. You can just see the image and answer it. Patient is suffering from which disease? Yes, type your answer in the chat box. A male patient suffering from alopecia. Which alopecia? Which of the following nail change is associated? So answer here is alopecia areata. Yes, so alopecia areata, where pitting over the nails is the finding associated. Pterygium is seen in lichen planus. Yellowish discoloration of the nail is seen in yellow nail syndrome. Sometimes it can be seen in onychomycosis. And pigmentation of the nail is a side effect of a drug that is minocycline. So pitting of the nail is seen associated with alopecia areata. And yes, very nice, Hari Om Sharma. Exclamation mark sign is also seen. Another very important question. Exclamation mark sign. Exclamation mark sign. And who will tell me that Henderson-Patterson bodies are seen in? Henderson-Patterson bodies. They are seen in molluscum contagiosum, and molluscum contagiosum are pink pearly dome-shaped papule with central umbilication. Another important point, Henderson-Patterson bodies. So with this, we come to the end of today's session. I hope you liked the session. We have discussed many of the important topics which have been asked in previous years in your screening exam. If you just go through these topics, definitely you're going to find it easy in your exam and you will be able to answer various questions. So thank you very much. Thank you for all the time. And you can just search my name in the Google, that is Dr. Manish Soni, and you will find my Google page. And there you can leave your feedback or a 5-star comment there or a feedback of this session. So thank you very much. All the very best for your exam. I hope you liked the session. Thank you. And if you have any doubt or if you want anything from any help from me, then you can definitely connect with me. This is my email address, manishsoni2003@gmail.com. So you can find me on the Google, you can find me on the Instagram, you can find me on the YouTube, Facebook, and you can connect with me. You can directly mail me as well. So thank you. Thank you. Thank you very much.